Okay, so we're going to be talking about the protocol for apical long access and doing your functions and so forth. I think one of the first things to keep in mind when you're scanning apicals is that your probe will typically never be flat on the person's chest. If it is flat, like on the person, as you can see, keeping it flat, it's going to cut through the stomach and all the visceral and so forth. So when you're going to be placing the probe in the apical position, you are going to have a lot of angle to it. So not all of your probe will be touching that spot at once. And it's going to change as we rotate and stuff like that. Also, angles. Angles are going to be really important as well. Kind of have to remember where you left off in parasternals. Then you can draw almost a diagonal line to her axillary line to find a starting spot. Chris and I kind of argue over like which way to go first. I sometimes go more medial first, and then I'm gonna go lateral. So I'll start at that axillary line. I'll move medial towards your sternum, or I'm gonna go all the way underneath and move very lateral, like almost on the side of the body. So again, axillary line is right here, straight down, and then the side of the body. So I use a huge window. Not all, I got caught in cords there. Not all of, are you fixing it? Thanks, Dan.
Mm-hmm.
So not all of the images are going to be in the fifth intercostal space. Again, we really have to watch the apex and the tissue to make sure that we're on axis. We want a carrot shaped on axis. Okay, so I'm going to go ahead and start. Again, notch towards 3 o'clock, so it'll be pointed down to the left side.
Do you want me still on my side?
Yep, all patients will still be left lateral decubitus. You're going to have to adjust your patient, whether rolling them forward or rolling them back. I don't know, I guess left lateral decubitus.
Does this bed have a dropout or?
This bed does have a dropout, so we'll be able to use the dropout. So make sure your patient is tucked in, because we are actually going to go underneath the left breast now. So I'm basically starting right at the axillary line, and I don't see much to begin with. As I push up into the breast, I can see more heart tissue. But the way my probe is angled now, the butt of the probe is actually in the bed. So I'm going to drop out this little panel here. Always make sure your patient's shoulder is above the dropout panel. So like here,
Just
yes, I have actually had somebody drop through it. Because, you know, you're just like, oh, they're comfortable. I ask them if they feel stable. They all say yes, and then they fall through. So now I make sure that my patient's shoulder is above. What?
I said little Justine.
Did that happen to her?
No, but it
she
would.
could just fit through the
She
hole.
might fit through the hole.
Oh.
You're gonna watch this.
Okay. So I started off really medial here, and adjust my gain so you guys can see. But if you look at the top here, do you see how it's more rounded? It's not a peak of a bullet, it's more rounded. I'm not a fan of it. So I actually went more lateral underneath the breast. Do you feel how far I am on your body?
Mm-hmm.
Yeah. And here, it actually created more of a peak in this corner. The first image, again, when we're doing apicals, is we want a really great on-axis, fully opened 4-chamber to show the difference in chamber size. So, breathing techniques. Abby, when you're ready, take a small breath in. Keep going, keep going, keep going. And blow it out. Usually the first technique I have is a big breath in. I want to see what happens when they do a big breath in. Then the next breathing technique I'm going to give her is, I saw it come in beautifully when she did a small breath in. So when you're ready, take a small breath in for me. And even that one was just a little bit too big. So blow it out. What I was looking at was artifact and how it covered. Okay? So a smaller breath in. Perfect. And breathe. And I'm a little off axis again. Just a little bit. I must have moved. Did I move?
A little bit.
Yeah. So I lost the peak here. And you don't want the RV to be up by that peak either. So I am just going to slide under just a little bit more. There you go. That's better. And a small breath in for me. Great. Excellent. Breathe. Okay. So I'm satisfied with this. Is it my best work? No. But it's great. I've got my atria are open. Both ventricles are open. I can see the base and the mid portion of my RV compared to my LV. And I have a carrot top at the apex. So if you guys are wondering what I'm talking about regarding the carrot top at the apex, you see it here? The triangle at the peak there? That's pretty much what you're looking for. Okay, so then we're going to start on function. Now I want the LV to be the star of the show. So first and foremost, I drop my depth. And there's a lot of tissue there that I don't need. So I'm going to reduce my width, which again increases your resolution. I'm at a frame rate of 83. That's awesome. My compression is set at 55. I can play with that if I want to. My octave is set well. Everything is looking good so far. So I'm just going to turn down my gain probably a notch here and maybe change my map. Okay, Abby, when you're ready, take a breath in. Breathe. So what you guys didn't see, but she felt, and I know she felt it, is even though I was in the lateral window to begin with, as she breathed in, I actually moved my probe along the same rib, medial. I'm in a completely different window now. And what it did was it actually brought in the endocardium. Do you guys see the endocardium? So it's the bright white on the inside of the cavity. So for you guys, and breath in again. All right, breathe. Let's try a little bit bigger. And big, oop, okay. That one really moved it. Now I'm really off axis. Okay, and breathe. Again, another thing that would tell me that I'm off axis is the window that I just landed in. Just to show you what that is, breath in. It's where the RV ends up being over or on top of the LV. You don't want that. Okay, you want it to be next to and underneath.
Are you rotating or are you moving the probe to?
I went very medial to foreshorten it, like I just did. Okay. And breath in. Now I'm going to take that breath in again here. Breathe. Good. So I did 2 of her LV. I'm gonna stay in the same window, and all I'm gonna do right now is I'm gonna turn the probe to 12. And then I'm gonna have her do, because it does not look like a 2-chamber right now, but I need breathing techniques to see what's gonna happen next. So breath in. Okay. So when she breathed in like a big one, her whole heart went off of the screen, which is okay. That's totally fine. You breathing normal?
Yep.
Good. So what I'm gonna do is I'm actually gonna drop lateral in her case to see if I can bring it out, and it worked perfectly. So can I have you take a small breath in and hold it? Nice, breathe. Do you notice how it squeezes together like this and the apex doesn't come down? Squeezes together. That's what you want. And another one. Good. Good. Hold and breathe.
And what does breathing do there? Like I just never see a difference when they have you like take a little breath like that. Like
Sure.
what are you seeing different right now?
Okay. So this is her without breathing.
Okay.
But this is the window that her heart shows up in when she breathes in.
So was she not breathing the whole time?
I get what you're saying.
Yeah.
No, I'm in different windows.
Okay.
I'm not in the same window. So this is a lateral window.
Okay.
Abby, take a breath in. Now I have to rock and turn to make sure that everything is coming in. But that would be it. And breathe. Now do me a favor. Take a real big breath in.
Okay.
Okay, blow it out. Your lungs push and pull your heart into the right spot. Okay, and then we're gonna do that second shot again, function shot. Now I'm gonna try to find a window where she doesn't have to breathe that much. It's also gonna help me when doing my Doppler. So I'm gonna find an easy window. Now my structures don't need to be coming in absolutely perfectly in this window. When I take the anatomy shots, yes, we want definition and so forth. But if my Doppler lineup is better when it's off axis, then we'll do it that way. So here, we take a full. I tilted my box because there is a little bit of a tilt to this heart. Oops.
Do you need your drink?
Where is it?
I think it's in the other room. I can grab it.
Yeah, I'm starting to, my nose is dirty. Thank Dan. I took a 2D of the left atrium. You don't need to. It's just part of my protocol. Now I'm gonna adjust my color box. Again, she just ate, so her velocities are gonna be super, super high right now. The best color box is gonna be annulus to annulus, and it covers down to the root. You can see a little bit of pulmonary vein there, and there's the descending aorta. There's a little whiff of mitral regurgitation there, so I'm gonna just take the image. And now, because I see a little bit of mitral regurgitation, I want to do a CW. I must have been practicing PDEF. Scale is going to be increased to about 5. And there we go. And 3 Dopplers presented. This is the start of a U, but as I said, it's traced, so we are not going to get a full envelope. Next, I'm going to look at the aortic valve. Again, annulus to annulus, covering a little bit of the ventricular septum. you can take a simultaneous picture. After the color picture, we're gonna drop our Doppler and do a CW. I did lower my baseline a little bit. I'm gonna increase my compression just a little bit. Sorry, guys. Actually, Dan, I need to blow my nose.
Yeah.
Do you have a Kleenex anywhere?
I got you.
I'll edit this out for later.
I bet time to ask a question, but
I don't know if I'll be able to answer.
You're like 50 years in mouse photo. No, I'm supposed
No tissue, but
Oh, I don't care right now. I'll step out and do this. I can feel it. It's warm in here.
She is all up on my titties. She's all up. She'll have to cut that out too.
oh god.
She's funny.
She's all up on It's all good.
Oh, great. I get to rewatch whatever you just said.
Yeah. You're gonna like it. You're gonna love it.
Oh, yeah? Can you give me 2 mediums, please?
Yes.
so this is a CW, and you have the baseline where it's cutting off the top. And is that just because we're looking at the aorta? We right now are only caring about the bottom, or eventually would we look at the top too?
So,
Yeah.
we adjust our baselines. To focus on specific things.
Yep.
Okay, so this one is, we can cut off the top, but we
Okay.
should show the top
Okay.
if it's not being shown here. So if there was aortic regurgitation, which she doesn't have any, then you want to make sure the
Okay.
baseline is maneuvered.
So same with like what we were doing last time, we could show above and below if we noticed that there was regurgitation.
Correct.
Thank you.
Mm-hmm. Okay. Sorry about that. All of a sudden I'm like, I gotta blow my nose right now. Alright. Back to it. Oh, that's gonna be right on your belly. Sorry.
Chilly.
Yeah. Oh. So again, we do CW first. Because again, we want to pick up the highest velocity.
You'll have to listen to it.
You don't know why we're laughing later. I can repeat it if you want.
What's wrong?
It's not you.
That's what Abby said. That's what Abby said.
What did you say?
I said she's all up on my titty.
Oh my god.
You're like that. You're on video.
Oh my god. Yeah, unfortunately, that's how it is. Oh, I'm so glad that no one is around right now.
Must be the time that the students walk in.
Yeah.
How's it going?
Well,
All right.
what if I said that as an explanation? I'm all up on
I
it.
know. That's what I was thinking. Like when they say, like, okay, we're gonna go under your left breast.
Awesome. All right, I'm gonna keep going at this. All right, here we go. So again, the goal is to be as parallel to the flow as we possibly can. So we're gonna put the gate will be parallel to the valve, and the cursor becomes perpendicular, it's gonna become parallel with the flow. The only reason why I said it's more like the gate is perpendicular to the flow, not the valve. Does that make more sense?
Like the jet?
Like the gate itself, if you're looking here,
Yeah.
it's parallel with the valve, but it's perpendicular to the flow.
Right.
Yes.
Yes. And then the flow is parallel to the cursor.
Okay.
So I'm just dropping this down a little bit. Again, I'm going to place the gate where I would measure the LVOT, and I turn on my pulse wave. Okay, and so again, with young, healthy adults, and if you have the correct angle, you're going to get a Doppler as beautiful as this. Just going to adjust my compression down a little bit more. Probably should have done this when I'm live.
Why do you like it to adjust the compression? What are you like trying to do?
Make it more black and white,
Okay.
not so much grayscale, so you can really see the spectral envelope. Okay. Remember how I said that tilting gets the aortic valve open? Well, if I tilt back or tilt inferior, this is a backwards 4-chamber, also known as the Mayo view. This is the view that they use to interrogate tricuspid regurgitation, which you can do. So if you're at a loss and you can't find tricuspid regurgitation in your other views, try this one. Just look at, there it's set, right there. Then if you wanted to, you could add this into your protocol by tipping inferior and then doing a CW. Almost. Not quite. Almost there. Cool, huh? All right. Moving on to the next part of your protocol. I'm going back to that 2-chamber, and I want a full 2-chamber in view. So not only did I rotate to noon on the body, but I moved it up and like hugged a rib space. Alright, so I take an image of a full 2-chamber. I grab my zoom box. Look at my left atrium in 2D. Put color. Now you can see her trivial mitral regurgitation very well.
Can you point at it?
Okay. Thank you.
Alright, and then I'm going to use my CW here. I increased my scale. I'm going to go 5.5. And I almost got a full envelope right here. Almost a full U shape.
So what does it mean if you only get a half?
It's really trivial. Yeah.
So you won't okay.
Hmm.
Makes sense. Makes sense.
So, as I'm holding the probe, notice how my finger will be placed on the person's body. Okay, yep. My whole hand is wrapped around the transducer. This gives me control. If you have somebody coming in with tamponade who's really short of breath, they're panting. So trying to get that picture to stay in when you're holding the transducer too low is not going to be possible. So literally, she probably, why that comment was made, was because my whole hand is flat on her body. And that's how you want it, and that's how you control the probe. This is going to be much easier on your arm than the other views. So it's kind of nice. And the majority of the transthoracic is done in this view anyways. yeah, so you're gonna be underneath. Now if you feel the pulling or tugging going on up here, tugging, adjust your chair. Maybe you need to move back or move forward. Make sure you're not feeling it. You don't want to be leaning. You want to have your arm braced on the bed like I did. Definitely don't lean because you're going to be in the spot for a long time.
Do you use the same grip for subcostal?
It's above.
Okay.
And then I push down. So it's different. That's nice about transthoracic is that you can hold the probe in different ways. The one that hurts me the most is parasternal long access. Now we're going to be in apicals and you're really not going to feel it.
Good.
Okay, so that was a full protocol. I may have done like 1 or 2 pictures out of order. I think the last 2 I did out of order. And I added in a view that you typically don't do, which is the Mayo view. Yeah, you can turn it off